Hi everyone, and welcome to our webinar this morning or this evening, depending on where you're tuning in from. It's lovely to have you here, and today we have two experts. We're going to discuss a comparison of the coronavirus epidemics in Australia and the UK. Just to give you a little bit of context for this, in July this year, we saw that both Australia and the UK had coronavirus case numbers in the hundreds. Yesterday, December 15, Australia had 8 new cases, while the UK had more than 18,000. We've seen 65,000 deaths in the UK from COVID-19 and 900 deaths in Australia, roundabout, all up. And we've seen lockdowns in both countries of sort of varying degrees of severity. There are similarities, despite these places being on other sides of the world. They both have similar democratic systems. They are both islands. So what I'm really interested to find out today is why they've had such different trajectories. In a way, we've seen other successes in other places around the world. Australia has, as they say, done well, but Australia has had also a very severe second wave that played out largely in my hometown of Melbourne. We've seen mistakes in both countries in terms of contact tracing, while other places like Taiwan, Vietnam, Singapore have done much better. So I think as we get to the end of the year and we look back on this horrible, horrible year that was 2020, it's very useful to make a comparison between these two countries and many other countries to see what we can learn from how different governments have handled this pandemic in their own countries. This is also just a very personal subject for me. I'm both British and Australian. I've been working on the UK epidemic. I've been talking to my family and friends in Australia and my family and friends in Britain. And I really find there's just this gulf of misunderstanding. The scale of the outbreaks is so different in these two places that I really want to try and get at why and how we sort of ended up here today. I don't have the answers to that at all. However, we are joined by two experts from each country who have both been following and working on the national efforts to contain coronavirus. So joining us from Melbourne, which was, as I mentioned, the centre of the second wave there, we have Catherine Bennett, who is a chair in epidemiology at Deakin University. Catherine was an incredible contributor to the conversation during Melbourne's second wave and afterwards, and has written a lot of really insightful pieces on the site that you can go and look at after this webinar rather. We also have, joining us from Liverpool, Tom Wingfield, who has a very long title, but I'm going to try. He is Senior Clinical Lecturer and Consultant Physician in Infectious Diseases at the Liverpool School of Tropical Medicine and Honorary Research Associate at the University of Liverpool. As if that wasn't enough, Tom is also working on frontline in the National Health System in the UK as a doctor on the COVID wards. I'm very thankful you can join us today, Tom, and also thankful for the work that you've been doing to save lives. So welcome to our panelists. Thank you so much for joining us. It is 8:30 a.m. in the UK. It is 7:30 p.m. in Melbourne. One of the greatest things about sort of doing things between these countries is you are never in business hours. So thank you everyone for tuning in. I'm going to start, I think, just to situate us a little bit. Let's start with each of our panelists giving an update on what the coronavirus situation is, where they are sitting today, and what kind of restrictions they're currently living under. And Catherine, why don't we start with you?
Okay, so the important thing to note that with our 8 cases today, that these are all largely imported cases. So these are our return travellers, and our last case of community transmission in Victoria that was part of this second wave actually happened 7 weeks ago. So we've had 40, 48, 49 days now without broader community transmission. We have in recent times, though, had a couple of events associated with our hotel quarantine. So we are an island, as you say, and we can manage our borders. But in fact, it's proving a challenge because you've just got this constant pressure all the time of increasingly higher proportions of travellers coming back to Australia positive because rates have gone up overseas with this broader second wave. So we had an outbreak in Adelaide, so one of our other states, South Australia, and that got into the community. They didn't know about it till it was the second generation of spread, and actually initiated another lockdown after Victoria was coming out of theirs. So apart from that, and that's really eased up. They went in and out of lockdown within 3 days. Really serious lockdown. In fact, in some ways more strict than Melbourne, as they just waited to assess the situation and didn't want to get into this long chase of the virus. New South Wales did have cases of community transmission, but never really went into lockdown. They had some occasional restrictions, but our broader, entertainment and our hospitality industry have always been subjected to some density rules. And so there has been some where they tweak it up and tweak it down depending on what was happening locally. In Victoria, of course, we had our world first, longest, hardest restrictions in place for 112 days. We've now gone through a number of steps in the roadmap out, and this roadmap was set up in September, and we had goals to meet. And even if you achieve the goals, some of them were linked to date. So it was whichever came later. So you might achieve the goals, but the date you had to wait still came after. But what's happened is we've become even more conservative even since putting this conservative roadmap in place. So we have more than met the final step, the COVID normal step on that roadmap, which should have really just taken us to density requirements and COVID safe plans in workplaces, and in fact in every place having a COVID safe plan. But in fact, we're not quite there yet. So we still have some limitations, number limitations on events like weddings. They're quite large now. You can have 30 people to your home. So they've lifted it, but they've still left these number caps in there for a number of parts of hospitality and workplaces too. You can only have 25% of your workplace back, and it depends on the size of workplace, and that will be easing further over the summer. But our final step, our COVID normal, was 28 days with no cases, an eye on what was happening in other states, and so to be at 49 days and still not be at the final step is frustrating. But after that long and that strict a restriction, and we'll talk more about that later, I think in relative terms there's just great relief to be out of the main restrictions, including rings of steel around our main city that stop people moving more than 5 kilometres from their home, or even beyond that, you couldn't leave the city at all. So a lot of people have dual homes or families in satellite cities around Melbourne, and so that was part of the lockdown that I think hurt a lot of families and really stressed a lot of people in terms of their connections and their work and a whole range of things.
Yeah, this is something that affected my family quite a lot, because my partner's mother lives on the border of Victoria and New South Wales, which itself was a ring of steel, and sort of for 4 months they weren't allowed to see their friends on the other side of the river. So I think there's a lot of people who must be feeling like they've come out of something completely incredible. But I must say, to me, here in Europe, sort of hearing 30 people at a wedding is just seems amazing in itself.
Weddings even more now. You can actually have, I think it's 150 people at weddings. So it really has opened up. It's interesting that we still haven't removed all the caps, and we still wear masks, but now it's public transport, supermarkets, and it's indoors. It took a long time. We had weeks of 0 cases before we even removed full-time mandated masks every time you stepped out of your home. That's only really been the last 2 or 3 weeks that they've eased back on that. So there's been a very cautious approach, incredibly cautious, and it's interesting that it actually became more cautious, not less, as time went on. But yeah, I think there's a lot behind that as well, which is we probably still, I don't know, we start to have some insight now as we're doing a number of inquiries in Australia into various elements, our hotel quarantine, our contact tracing in Victoria, that I think it's going to take years to really fully understand what we did, what worked well, what you'd hang on to, which bits you might do differently.
Can I just ask one tiny follow-up question as well? When you, just maybe not even in your capacity as an epidemiologist, but your capacity as a Melburnian, say when you're walking down the street, I suppose you have a mask on, but does it feel normal, or does it still feel like you're in a pandemic?
We don't have to wear a mask now out on the street, though some people
Great.
still choose to do. We've got some great, fashion statement masks now because it's became such a normal part of living, and it's good to see people still, just leaving them on rather than putting them on and off as they go in and out of places. Look, there are times where you could almost forget. But at the end of the year, we've had a lot of wrap-up sessions and people showing photographs of things that they were doing during lockdown, and you see a lot of photos of our city in lockdown, and it makes me cry. It was, a great, vibrant city that was completely shut down for so long, and it was massive. And I remember at night time, I'd just go on and check this. You have the street cameras on your computer. You can just log in and see live footage, and you'd be looking at a massive arterial road in Melbourne at 9 o'clock on a Saturday night, and it would just be vacant, but you just had to keep looking to believe it. Or I'd look at the flight maps out of Tullamarine Airport, one of the busiest airports in the country, and you could just see half a dozen planes within the vicinity, and normally it would look a little more like Europe. So it was incredible actually to see the shift and for everything to go quiet. And there's some remarkable stories about what that does to you, and how simple things become so important. But the first day I met with someone other than my partner, when my brother and his wife could come and drop in for a cup of tea, it was extraordinary, and you just wouldn't think that something as simple as that would become so special and so valuable, but it also, I guess, shows you how much we were really hurting for many months there.
Oh, I'd love a cup of tea with my brother right now. Tom, if you're watching,
Yeah.
maybe next year. Sorry, Tom is the name of my brother, but also the name of our next panelist, Tom Wingfield. Do you want to tell us a little bit about what the situation is right now in Liverpool, which I imagine is incredibly different to what we're hearing from Melbourne?
Hi, Megan. Hi, everybody. And thanks for the opportunity. Unfortunately, Liverpool was hit by a really severe second wave of coronavirus throughout October and leading into November. And we were actually put into the highest of the government's 3-tier system for restrictions. We also were the first city to have mass testing with these lateral flow assays introduced. And happily, since then, the number of cases have reduced. But we're still having 500 cases per week. Our rate's 90 per 100,000 population. It was 700 per 100,000 in the peak of the COVID wave. And at the minute, what we're seeing is that things have kind of plateaued now. They seem to be, the infection rates seem to be static. The deaths are still decreasing, but obviously since the 3rd of December, when we opened up from the national lockdown, we're just waiting to see the consequences of that, and obviously going into Christmas, where we're allowed these 5 days of mixing of 3 households. I think we'll talk about later perhaps, but I think we're just thinking forward to what that might mean. And we're currently in Tier 2 in Liverpool, and what Tier 2 means is that there's no indoor household mixing, apart from with your own households, that you can meet into up to 6 people outdoors. You can go to a pub and restaurant if they serve a substantial meal, and actually saw a great article in the conversation about whether a Scotch egg, which is this egg covered in meat and breadcrumbs, constitutes a substantial meal, which has created much debate in the UK. People are working from home, but obviously some of the other things remain open. So retail, shopping, hairdressers, hotels, nurseries, creches, schools, higher education institutes, although most of the universities have gone home now in a staggered way, but those have remained open, and are currently open. So the restrictions aren't as severe as when we were in Tier 3, but there's still quite a number of restrictions to our daily life.
Can you explain a little bit more for, say, our viewers from Australia or outside the UK, what the tier system is and how it's being applied across the country? Well, it's just for England, sorry.
Yeah, so the tier system really is a 3-level system, with 3 being the highest tier and the most severe restrictions. And really that's when everything shuts down. So, pubs, restaurants are no longer able to open, non-essential retail is no longer able to open, hairdressers, etc. are closed. And in some cases, people have made the decision for certain higher education institutes or schools to adapt their learning and maybe have some blended learning. And that was introduced by the government because it was felt that there were disparities in the numbers of cases and changes over time in the rate of cases that required a regional response. But obviously, as you'll have seen, actually we went into a national lockdown to try and curb those cases, which we came out of on December the 3rd. But essentially, the tier system is just a graded system for areas that meet certain indicators to do with rate and number of cases that need enhanced restrictions. And that's what the government brought in here.
And you're an infectious diseases physician, Tom, and you are currently, well, not today, you're joining us, but currently caring for COVID patients on the wards in Liverpool. As a person who is doing that, how do you feel when you're walking around in the community and seeing the restrictions that are or are not in place? What are the things that you feel when you're kind of walking around Liverpool?
So the first thing I'd say is I think that we really have pulled together in Liverpool across the community, across the hospitals and primary care, secondary care, and also the universities and the research institutes have really pulled together to have a kind of collective response to this. So I think that I feel very proud to live in Liverpool and work in Liverpool and of the response that we've had. Thinking in terms of what I see when I'm on the wards with people who have COVID in the hospital, obviously anything that increases contact between people in terms of health and in terms of likelihood of coronavirus, it does concern me. And the Christmas period does concern me. And I think that we are creating conditions that will inevitably lead to a rise in coronavirus cases, especially with the numbers that we currently have. But I also understand that people have are much more complex than just their health. And there are obviously social and economic implications of lockdowns. And I think that people do need support, especially vulnerable people in our communities need contact. And so there is obviously this interplay and trade-off between what we need as humans, especially, as I've said, those people who are most underserved in our communities. So a mixture of feelings, I'd say.
Yeah, I think that's very common amongst all of us, even those of us who are not COVID doctors. It's that kind of trade-off that we're thinking of. And Catherine, I think, when Australia, or particularly the state of Victoria, started thinking about that trade-off in July, it went in a very different direction to the UK and to many other countries. Can you talk us through briefly, because I know we've sort of touched on it already, Melbourne's second wave for people who aren't aware of what happened there?
Yeah. So the real tragedy almost of the second wave was that Australia had arguably achieved elimination of local transmission, and that included Melbourne and Victoria. We'd had a few cases linked to a meatworks outbreak from the first wave, but the first wave we weren't testing in the community. We really didn't have a good picture of how much community transmission there was, but we went into what was called stage 3 lockdown, which was pretty strict. It actually meant we did close retail, restaurants were takeaway and so on. It was before masks were mandated, but it was a real step up from anything we've ever experienced before. So people complied. We did get a real reduction in mobility and all the measures look good. And in fact, when we came out of that 6 weeks later, we had, to all intents and purposes, stopped that community transmission, even the ones we didn't know about. And so the virus that was circulating in the first wave completely disappeared by June, July. But in June, we had this leak from our hotel quarantine system that actually the tragedy in it was that it infected a number of security guards before it was detected. And they took it home to different parts of the community. So we wound up with this broad seeding into a number of different areas. And the other part that was a real challenge in this, and a tragedy for the people at the centre of it, was that they were security guards had been brought in on contract work. So they were people who were in insecure employment, often parts of large families in really well-connected migrant communities in various suburbs in our city that, that very connectedness at the community, and the fact that they were sharing households with other adults, with often, extended families who were often doing more than one job, meant you couldn't seed the virus into a community in a more effective way. And very early on, one of those people infected was from aged care. So the second wave was very different. It hit workplaces and we saw this rapid escalation. So we only started, we had a few cases, we had the odd day of zero. Then in early July, so about the 4th of July, it started to look more serious. We had 69 cases all of a sudden, who were these contacts of some of these early known cases. 3 days later, 164. 3 days later, double that again. And that was the real alarm bell. So by the 9th of July, we actually moved into stage 3. And that sounds a little bit like Tom's description. We shut down retail and so on, and schools. And we had about 3 weeks or so, and then we brought in masks as well, mandatory masks. And so I was tracking our case numbers and doing the poor man's version of a R0 number, which actually wound up being pretty close to the modelling being done by the health department as well. And it did. Our stage 3 brought our R0 back towards 1. But they were concerned it was going to be too slow. And we were starting to see the rise in deaths because so many of the cases were in aged care, and we went from a very low, less than 1% death rate or case fatality rate to 4%. And so there was this real concern that it was just going to get worse if we didn't really shut down community transmission to protect aged care.
And can I just ask the R0 number, that's the reproduction number?
Yeah. So looking at, yes, how many cases over an average incubation period, how it relates to the previous, and therefore, projecting what the next might look like.
Great.
But when we brought in the masks, it actually brought that down below 0 to something like, 0.7 or so. But only 10 days after the masks, there was this real panic, and there was starting to be a mood shift in politics, in the commentary, in the public. And some people were saying, this is overkill. What are we doing? We managed this the first wave. Why are we now talking about much more strict restrictions? And there've been a few people out in the media really pushing that, and the government decided it just had to make the call. It wasn't going to wait and see. It was going to do that. But that meant shutting down absolutely everything. Everybody then had to work from home unless you're an essential worker. You had to have work permits if you were able to go out to work. Everything was closed. Schools were closed. Universities closed. It was just extraordinary. We just completely shut down the city, basically. And so there were very limited reasons where people needed to travel, and it was mainly the healthcare workers, police, and so on. And it also was backed up with new restrictions. So we had a curfew put on from 8 o'clock at night till 5 in the morning, and we had limits on how far you could move from home. You couldn't leave the home for more than an hour for exercise. You had to do that just with your household, or you could do it with one other person if you kept your distance. Only one person could go to the supermarket, one person per day. And so there was this whole range of things. The supermarkets shortened their hours. And some things that were confusing me as an epidemiologist, because you're actually pushing people together in some ways. It's like putting a curfew on. If people are allowed to go out for limited things, you kind of want it to be spaced out over the day. But it was, the same thinking. You could only meet 6 people in the park, or 5 people in the park for us, I think, initially, outdoors when we started to ease restrictions, but they could be from 5 different households. So it was all, it was, I was sort of thinking households matter, it's not the head count. Larger households are going to just split up and meet different people. So it was a real shift, but it continued to keep the R0 below around the 0.6, 0.7 mark. And so by the middle or late September, we were down to less than 10 cases in a day, and we didn't have more than 10 a day basically after that, and right through to the end of October where we saw the last case. But that period from middle September until the end of October, we were still in this really quite strict lockdown with a ring of steel around Melbourne, and the cases were linked to outbreaks that weren't being shut down. Some of them were being fed from these outbreaks that persisted all the way through in aged care and hospitals. And they were linked to known clusters that were then related to a new cluster that would pop up somewhere else. And so it was a frustrating time because you knew these outbreaks were pushing it, but our health department was concerned there would be all this other transmission happening out in the community. And as an epidemiologist, I thought there shouldn't have been. After 6 to 8 weeks, you should be suppressing it. by 110 days, we shouldn't have seen any more transmission. And so, of course, when they closed down those last related outbreaks, clusters, we haven't seen a case since. So, we really had shut down transmission, but we're also rebuilding our health system at the same time. And I think there was concern it wasn't safe enough to open up with even 10 cases a day, even 5 cases a day. So that was the challenge, was actually having assurance that, the health department's response was now up to it, for them to have the confidence to also open up and not signal to the public that, in fact, we're not confident, then the public won't be confident. So we did have a lot of the public who were really terrified about coming out of lockdown, and others who were just so frustrated, particularly obviously business community and people worried about mental health impacts. So it was very, very challenging and divided, because we didn't have a clear end game. We did have a roadmap. It had our steps out, but we haven't stuck with that. And so, again, you don't have that kind of, at least we got here. It's very conservative, but we got here, because it's like, we got here, but we're going to keep the 5-kilometre rule. So that's the sort of, I guess, exiting out. But it did mean that we, conversations about suppression versus elimination, you have to suppress to get to elimination. We'd well and truly reached elimination by the time we opened up.
Mm. Tom, I'm interested, Catherine mentioned the pressure on the health service. Obviously, you're a frontline health service worker. Can you talk, for those who haven't read it, actually, Tom and his colleague Miriam wrote a really wonderful piece for The Conversation in recent weeks talking about the challenge of caring for COVID patients during the second wave in their town. Can you talk a little bit to that, Tom? What you're seeing on the wards and what it's like, how the healthcare system is coping with this second wave of coronavirus.
Yeah, thanks. I suppose to take a step back in time slightly here in Liverpool, but it's relevant to what's actually happening in many parts of the UK now. So in mid-October and towards the end of October, really our services were extremely stretched. We had high numbers of hospital admissions, high numbers of intensive care admissions, and we were struggling with capacity across the region. And this was on the background initially of not having a national lockdown, but as I mentioned, being in tier 3, and having a workforce that has already been through the first wave of coronavirus, and in all honesty is tired and has not had enough time off, and has not really had a chance to reset, as you often do when you get some time off, just to get yourself together. But obviously very committed to trying to serve the communities with which we work. And I think that's what is happening in certain parts of the country now, as the case numbers are still increasing in some certain parts, and even in the region in Cheshire and broader Merseyside, which is the region around Liverpool. Actually, the hospitalisation numbers still are just peaking now. And so, there was an intense pressure on the services, and this on the background of intense winter pressures anyway. Hospitals often run at capacity 95% or more each winter in the UK. And so on that backdrop, it just adds further strain to the healthcare system. Plus the fact that obviously we as healthcare workers also are affected by COVID-19. If you're a healthcare worker or your household, you have about 2 to 3 times the risk of having COVID than other households in the UK. And having to take time off, having caring responsibilities, and having to isolate. Obviously now things have got better with more rapid testing and regular testing of healthcare workers. But it has been difficult times for us here, and I'm sure it's the same for many other healthcare systems around the globe that have been severely impacted by this.
I think it's an interesting comparison that I mentioned at the start of the call, that we're dealing with 2 islands with 2 very different strategies. And we've seen that Australia's strategy has been to basically shut the borders and implement this hotel quarantine program. which, has in some senses been successful. In the other sense, it was the source of the second wave. Tom, in terms of the UK, obviously the UK did not go down that route. It does have some self-isolation rules or self-quarantine rules for incoming arrivals. Do you think that it was ever feasible for the UK or desirable for the UK to close the borders in the first wave, which I know is sort of where we have the data?
So I think it's a complex question, and I think it does lie slightly beyond my comfort zone. But I'll try and break it up, the response. Is closing borders possible and feasible? Yes, it is. It is possible and feasible. And if you look at examples, for example, like New Zealand, where within a month of their first case at the end of March, they had put in place a 7-week stay-at-home measure with major restrictions and closures of their borders. Yet, yes, it's possible. And obviously you can see and read for yourself what's happened in New Zealand in terms of their case numbers. Is it desirable? It is subjective and it's complex. And I think that that's a difficult question to answer, especially if, for example, you have loved ones abroad returning home. Obviously, there's issues that the government would be considering, such as business. But I also think that closing borders alone, once you have reached a certain threshold and there is community transmission, it is only obviously part of the response. And I think that the lockdown and the kind of checks that we had on the borders were implemented relatively late in our epidemic curve in the UK. And they also require a number of adjunctive responses to be effective. And that's adequate, sufficient contact tracing, which is using rapid and accurate tests. Plus the fact that I think Catherine alluded to earlier when she was talking about the security guards is the fact that we know that a number of people, a significant proportion, will have asymptomatic or pre-symptomatic COVID, which makes it very, very difficult to put in place checks that are rigorous to identify people who will then go on to potentially transmit. So yeah, I think that timing is critical. And I know that here, for example, the Home Affairs Committee in the UK has looked at that, and they have said themselves that they felt it was a serious mistake that there was an early closure of the borders. And also that it was difficult to explain why the UK, on the 13th of March, the UK government decided to do away with quarantine measures at that time for international arrivals without symptoms. It's a bit unclear as to why those decisions were made. So I think those are things that we can learn from.
That's great. And I want to come back to you now, Catherine, to just develop some of these points that you made earlier about some of the restrictions. I think some people who are not in Australia might be surprised by just how severe some of the restrictions were. So earlier in the year, we saw residents of public housing towers in Melbourne basically sealed inside the towers in their thousands with, I think it was sort of very short notice, not allowed to leave their apartments at all, and sort of, the government dropped off food parcels and that type of thing. And then you mentioned also the Adelaide outbreak, where again the virus coming out of hotel quarantine led the state of South Australia to lock people down, but say it was not possible even to leave the house to exercise or to walk the dog. If I couldn't walk my dog, I don't know what would happen personally. but these are very, very, very severe restrictions. Do you think that kind of response is justified, given that obviously we have this great result in Australia with such low number of cases, or do you think there are problems with restrictions that are that harsh?
Look, I do think there are problems. South Australia reneged on the dog walking rule within 24 hours. And the idea of being stuck in your home with your children is something, but your, large dog that's used to 3 walks a day, it would have been even more problematic. I think, you go to these very strict blanket lockdowns when you really don't know what's going on. And you don't quite know how the virus is moving through the community. You don't know where it is, and there's a lot of unknowns. And so you go blanket. what frustrated me was we went more blanket as time went on, not less. And we had the rich data coming in on the cases, but because we were in case follow-up contact mode, we weren't analysing the data in the way we normally would in other outbreaks to try and understand the source and the risk. And, if there are mystery cases, they'd call them people you couldn't link back to other cases. What's their profile? Who are they? How do we understand how we can minimise that risk? And so it became much more focused on the response. And the problem with lockdown is, as you said, with the towers, the same rule has very different impacts depending where you are. And the first level of serious lockdown was with these public housing towers when they found a number of cases linked to the same group of towers. And these are public housing, they're multi-storey high, you have 360 people in each tower. And by locking people in their homes, of course, they have no outside. They only have a small window gap that they can open. And it was done at very short notice to try and stop people moving through community. And they tried to think of everything. They tried to get the local community services coming in and support services. They had people coming in. The police were walking people's dogs for them and taking them out. But you can't just do that sort of thing on the fly. And we learned from that you need really good community engagement, and people will listen to their trusted leaders, not necessarily to a government representative or the police. So there are a lot of things out of that triggered even a much more devolved public health response really stem from that, where the government itself recognised this was a partnership and needed to be done that way. So I don't think we'd ever do it quite the same way again in that regard. For the rest of the state, though, I particularly Melbourne, which had the most strict restrictions, I think I'm hoping we will be able to unpack the data and go back and look and see whether things like the curfew added what they added, and this 5 kilometre rule. If we see that we had more widespread dissemination earlier on and that was contained, good. And you would say next time we know what that does and we can make decisions about when we implement it. But, we were never presented with any data that really showed that there was a change in pattern to the outbreaks once these things were introduced that actually gave me as an epidemiologist confidence in them. And if you're putting in extra safeguards that are actually, really punishing for people who are in social isolation or now out of work and have financial stress, there's some really good policy decisions about supporting people financially, but it was really that social support and the isolation and the fact that they might get temporary support for salaries, but the chance of the business they work for surviving this were getting smaller with every day. So I think there are a lot of questions about that, and I do think that in the end, our Premier himself, who's was a health minister in his past, so he was very hands-on with this. He stood in front of the press conference every day for the entire period. It was extraordinary. But at the same time, they would be saying really fundamental statements like movement equals virus. And if we let people move beyond 5 kilometres, even when they relaxed restrictions so you could meet people from one other home, they said if you're allowed to move more than 5 kilometres, you'll be too tempted to meet more people and you'll break the rules. So they'd think that having a 5 kilometre rule would stop you breaking other rules. But in fact, if you follow rules, you wouldn't be visiting other homes anyway. But the fact is, the one home you might want to visit, which might be your elderly mother, might be more than 5 kilometres away, and you couldn't go there because they sort of had a sense, oh, well, it's good, no one's moving, that's good for the virus. So I think we do have to understand, as Tom said, it's the contact between people. It's not how much you move, it's what you do when you move. It's where you're going and what the risks are at that place. And I think we have to learn from the experiences right across the world to understand what's too much, what's the right amount in a given situation, and what's too little. And I think that's the learning which will really benefit from the fact that we've actually done it differently around the world, and we can then say, okay, this is what we need to do. New Zealand, when they did have cases, didn't go in the same way the second time as they did the first time, which is interesting. They sort of pulled back, had local lockdowns and so on. So I think, we all want to be learning and as we go ahead.
So one thing I think that we've seen from countries that have truly done very well with this virus is successful contact tracing. I think it's fair to say that's been a bit of a problem in both the UK and Australia. Tom, can you talk a little bit about some of the issues that we've seen with contact tracing? I think it's best to confine that to England because these are, just for our listeners who are outside the UK, there's obviously 4 nations in the UK, and a lot of the coronavirus and health responses are being devolved to those nations. So the test and trace system that I'm going to ask Tom to talk about exclusively operates in England, although obviously all the nations are contact tracing. I think that's right. Is that right, Tom?
Yeah.
So what are some of the problems that we've seen with the test and trace system as it's known in England?
Yeah, so I think the first thing to say is that England and the UK has experience in contact tracing, both in the health sector and also in the environmental sector. And I think that we have seen issues from early on, especially during the first wave of the coronavirus pandemic here, with ability to scale up contact tracing to the level that was required, given some of the issues we had about late closure potentially of borders and the community transmission that we were seeing in that first wave. And some of the issues have come from centralization of that contact tracing, potentially a lack of community involvement or ownership, which I think leads into some of the questions that I see from the chat about reaching underserved, including minority ethnic groups, such as Black Asian minority ethnic groups here in the UK. And I think a lack of collaboration with local councils and people on the grounds who are used to doing contact tracing, who understand their local communities' needs, how they work, how to access the people in their local communities. And we know that even now, the test and trace, for example, the latest data from the final week of November shows that there were 17,000 cases, potential cases, or at least contacts that were not reached. And so that's we're only reaching about 60% of the potential contacts that we should be able to reach. And that's far from the level that's advised by SAGE, the scientific advisory group that advises the government. And so while we all know about WHO's test mantra, and I think it's extremely important, I think in the absence of rollout of a vaccine, effective treatment prevention measures, we still need the raft of other measures alongside test and trace that we've already talked about: social distancing, masks, hand washing, and the wider restrictions. I'm involved with a group at London School of Hygiene and Tropical Medicine that is doing modelling about transmission. And I think there's quite a lot of unanswered questions, actually, and maybe Catherine would have more insight into this than me. But for example, things like household composition, multi-generational households, the density of people living within that household, how old the people are, how many people are in kind of jobs that have higher levels of contact, and behavioural aspects within households that increase transmission. So that modelling, we know, does feed into policy, but there are still lots of unanswered questions there.
Sorry. So we've seen one area in which the UK has been ahead of the whole world, and the first in the world is in the rollout of vaccines, which are already being given to elderly populations, and I think they're being given to healthcare workers, which is wonderful to hear. I think we all want to make sure that frontline workers are protected from this disease going into winter. What you mentioned vaccines just briefly then, Tom. How do you think that the vaccines that we've already seen approved and the ones that are awaiting approval might change the trajectory of the epidemic in the UK?
Thanks. So I think that with the rollout of vaccines to elderly people and healthcare workers who are most vulnerable, I think the initial impact, we hope, will be a reduction in cases and hospitalizations and deaths. And obviously we know that age alone is a risk factor for severe COVID, but also there's overlap between age and comorbidities, chronic illnesses that also make people susceptible to COVID-19. So I think that it's right, that prioritization is right. And I think that if you look at other age-focused vaccination programs, let's say flu or pneumonia, they're actually feasible and a bit easier to implement perhaps than wider vaccination schedules. And actually there's good take-up often of those vaccines. I am concerned, just like we talked about before, that the vaccines reach, again, some of the communities that we've talked about. And I was listening to the radio earlier today in the UK, there's a study just being published, I think a survey that suggests that some Black, Asian, minority ethnic communities may have reported that they would be less likely to accept vaccination than white or non-BAME communities. And I think that's of concern. And I think that this is something that goes part and parcel with all the things that we've talked about, and making sure that we address the stark inequalities that COVID has really not revealed. They were there, but again shone a spotlight on them. I think more broadly, we don't yet know the impact of the vaccines on transmission of COVID-19, on asymptomatic coronavirus, and also what it will mean for long COVID sufferers, and whether or not there will be an improvement in that, for example. But I do hope that the vaccine will allow us in the short term to support those people more easily who are older or vulnerable, who need support, for example, with activities of daily living, and be able to just be together a little bit more and again, show solidarity to those groups.
Catherine, what's the plan for Australia and vaccines? And I imagine it's a very different situation rolling out a vaccine where you don't have community transmission, but you still want to maybe get back to normal and open up those borders.
That's right. It will have a big impact on us in terms of both the effort we have to put in to maintain these borders safely, with so many people returning with the virus, and but also for our opening up our international borders and taking out the last restrictions in Australia as well. And I think, as Tom said, the real issue here is people's trust and acceptance of the vaccine. And so not having to push for emergency approvals is actually a really good thing for us. We're in a position to go through our normal regulatory processes, which will happen over January. We're looking at very late February, March before we start to roll out. We're probably looking at, we'll be reviewing both the Pfizer vaccine and the AstraZeneca Oxford University vaccines. And so we'll be in a position to hopefully, the AstraZeneca we can actually produce in Australia as well. So that will give us, I guess, a slightly less competitive process for acquiring the vaccine. But really the important thing is having the plan to roll out. And I think our frontline, particularly our international border, will be part of our vaccine strategy. They've already announced they'll start with people over 85 and then work down in 5-year age groups, very similar to the UK, and look at our aged care workers and hotel workers in particular, but also our broader health teams and our police and so on. So I think there's a clear plan, but we won't get anywhere near finishing it by the end of 2021, even with a straightforward rollout. So working on both the vulnerable but also the risk areas for introduction of the virus, and then the second layer is those risk areas for amplification should the virus get into the community. That's the strategy. And unfortunately, what we learnt with our aged care is that it's an incredibly volatile area. We had lots of people working across multiple aged care centres, so they would actually go from one residential aged care to another and take the virus with them. And so it escalated both through the aged care sector as well as feeding virus back into the community with all these new workers being infected. And so, those areas where you happen to have your vulnerable people, most vulnerable in those settings, as well as this transmission risk, are obviously our main targets in the first case.
Great. All right. Now I want to go to some audience questions because we've had a lot that have been coming through. I think a lot of people are as curious as we are about this sort of comparison between these two countries. They should be popping up on the screen. And here's our first. So how far is the fact that Australia is in its summer the contributor to the low COVID numbers in Australia? And does that imply we'll be back to a new normal after Easter? And that's something I think is very interesting. Both of the second waves that we've been talking about have occurred in winter. Australia's winter in June, July, August, and now going into the UK winter, December, January, Feb. I'll ask you both about this, but Catherine, we've got you first. So what do you think?
Look, I agree. We had to deal with it over winter. It came out very well into spring by the time we listed our restrictions. The trick for us will be keeping community transmission free. If we can do that over our summer, then we'll actually be in a better position than the Northern Hemisphere, in that it was those levels of local transmission that could be suppressed by being outdoors and sunlight and all the other things that work in your favour in summer that could then flare up. What we're aiming for is to keep the virus at the gate. And so it'll be onshore, but it'll be in our hotel quarantine. And if we can keep it there, then we won't be at the same risk coming into autumn. But we're preparing for that because, again, we don't quite know what's going to happen with the vaccine rollout. It'll be very early days for us. March heading into Easter will only be in the first weeks of rollout of the vaccine. And that's going to take a time before we have that sense of a protective effect. So hopefully by Easter, we will be still where we are now, probably. I mean, that's probably the best we could hope for, but we'll probably have had a few more stepped easings with more people who can work from home now being allowed to go back into the office. So there'll be a bit more shift still, but the idea is to keep local transmission free in Australia.
Tom, what role is winter playing in the UK's second wave that you're seeing?
I think that the key message here is that people's behaviour and human contact is the main driver of spread, and that's influenced by the seasons. And I think that some systematic reviews of available evidence have shown that warmer and more humid conditions alone won't necessarily reduce the transmission of COVID. And actually, there's a lot to do with, as I mentioned, behaviour. I am obviously concerned in winter. We always see a lot of flu and pneumonia cases, and there is some emerging evidence to suggest that co-infection with flu and COVID-19 may be more severe or lead to higher numbers in terms of mortality. So that is a concern. And I think that generally hospital admissions obviously are higher in winter, and that will be compounded by increases in COVID cases.
Can I just add?
Yes.
It's interesting, the flu story, because our flu numbers were so down because it did start when we were going into winter, and we had one case in April instead of the normal numbers, and so 9,000 cases you'd expect. So some of the people who don't quite get COVID even now say, well, so we've actually got a deficit in deaths, if you want to talk about it in that sort of terrible number game way, saying we've had less deaths than you might expect, even with the COVID deaths there. But of course, that's what that incredibly strict lockdown did. It prevented more COVID deaths than we saw, and we did have nearly 900 now, most of those in the second wave in Victoria. But we also absolutely helped stop a number of other pneumonia and general influenza cases that normally contribute, massive numbers of deaths. So, I think it's we have to remember that it's not trading off. In fact, the lockdown worked on both those things.
Let's go to our next audience question. This is a tricky one. Do your best. Has the Australian population taken the restrictions more seriously than people in the UK? So, I mean, this is a wicked question that we come up a lot. How much is sort of individual rule breaking or rule abiding contributing to waves? Tom, why don't you start with that one? Give it a go.
Okay, thanks for the question. I don't think that you can put the differences down to a single thing. Including behaviour. And I think that in general, the vast majority of our population in the UK has really tirelessly stuck to the restrictions that have been put in place, which has been hard. So I haven't seen any good evidence to suggest that there is a huge difference between adherence to those restriction measures, but I'd be glad to review some if it was there. But I think this is a combination of geography, politics, epidemiology, across those factors that leads to the differences that we see. So I wouldn't put it down to restrictions not being taken more seriously in one country or the other.
Catherine, what do you think?
I absolutely agree with Tom. It's not so much just about individual compliance, it's also the level of restriction you've put in place. What was disappointing to me as a public health practitioner in the second wave was that we really put a lot of emphasis on punitive approaches to supporting restrictions. And so we had fines if you weren't wearing a face mask, if you were found more than 5 kilometres from your home, if you'd left the ring of steel around the city of Melbourne, and some of these went into the thousands of dollars. And so, particularly if you're a business that opened illegally. So there was a lot of enforcement, and the emphasis was on enforcement, and there was a lot of effort put into public presence. We had our Australian Defence Forces brought in to support the state, but of course now you've got soldiers, which we're not used to seeing on the street in Australia, and they're manning roadblocks to stop people leaving the city. So it was very different, by the second wave. First wave, really good compliance. People are generally understand that you need to do things for the public good, even if they annoy you personally, and even if they might not make a difference to your own health. But we had some fatigue in the second wave, and I think we moved very quickly. And again, I hope it wasn't necessary. And I hope when we go back and look at all of this, we'll think, okay, we might not do it that way next time. But yeah, certainly there was so much enforcement for the most serious restrictions that no doubt, was a factor.
Mm-hmm. So let's go to our next question, which it sort of relates across the board, but we'll start with you, Catherine. How have Aboriginal communities been affected by COVID-19, and have we seen the same disproportionate effect on minorities communities as we saw in the UK?
We saw a lot of our minority communities, particularly our refugee populations, being impacted, and that was a combination of exposure, their living conditions that we've talked about in terms of likelihood of infection spread, but the majority of our serious cases were in aged care. So we didn't get a good breakdown profile of the people who were hospitalised, and that's something I think we will learn as these numbers are unpacked over time. The Aboriginal community was largely, we have a lot of our communities in regional Victoria and then across the rest of Australia who weren't nowhere near as impacted as Victoria. But our communities within the city of Melbourne were actually very adaptive to this. They have such strong social connectedness that there's been some really good examples that we could all learn from about the way they supported people living on their own within the community. And so there was a lot of Aboriginal leaders and a number of our Aboriginal communities who just said, we're going to do it this way, and did it that way. And I think a lot of our other communities would have done better had we had that sort of similar system or that similar reaction, so that we think, okay, this is what we need to do to actually address some of the risks that come with this level of lockdown and isolation.
Tom, perhaps not speaking to the Indigenous communities angle, but we've talked a little bit about minority communities in the UK, and that's been very stark in my covering of this issue, how much worse affected minority communities have been.
Yeah, absolutely. It really has revealed those inequalities. In the first wave, more than a third of people who were admitted to critical care were from Black, Asian and minority ethnic groups. And we've seen from kind of trying to unpick why that has happened, that it is complex. And initially there was some thoughts about comorbidities and higher rates of, for example, diabetes or hypertension, which are also risk factors for severe COVID disease in certain communities, for example, people from South Asian communities. But I think we've seen that it's a lot more complex than that, and it may also relate to factors such as poverty, crowding, and again, like I mentioned earlier, household composition. We have to address these inequalities. We cannot today live in a society which tolerates these inequalities.
So we have 2 minutes to go. So I'm going to give you 1 minute each to talk about what you think are the key lessons from the way your country has dealt with this pandemic in 2020, perhaps for 2021, where we might do a bit better.
I'll just be very quick. I think, and there has been recognition of this and increasing in recent times, but it's partnership with community to actually have public health interventions work. That's everything from testing through to contact tracing and cooperation in that space, isolation, quarantine, and all of it. So I do think our communications and our relationship with leaders in the community should be a starting point. And that's come out of our inquiries. That's what's missing or was missing in our contact tracing that's now being built in. So there's a lot to be said for taking some of those fundamental lessons, and as we go ahead, then being in a position to design nuanced responses that fit the circumstance, that can be defended. And when I talk about relationship with community, it includes business community. In some places that was done well in Australia, in others it wasn't. And even if you ultimately go down the same path, if you take people with you, it really changes the whole mood, the whole compliance, and also offsets some of the potential damage that this trade-off between very strict restrictions and the impacts that has on economy, broader health, and a whole range of things as well. So I think seeing it as a partnership between government, industry, community, and recognising that it does discriminate. These viruses do discriminate, and they will find our weak points, and we have to be open to that, and we have to be open to reviewing what we've done now to get better at this as we go ahead.
Great, thank you, Catherine. Tom, what are your lessons for 2021?
So I'd say three things. I've already talked about addressing inequality, and I think this is an opportunity to do that. The second thing I'd say is communication. So I think we need evidence-based information. I think we need to try and counteract and mitigate fake news and misinformation. I think we can be helped by reliable media reporting there. I think we need the voice of local communities in what we're reporting and what we understand about COVID. I think that experts need to talk about what they're expert in and not stray beyond. I think we need to be unafraid to admit when we don't know, and recognition that the things we say one day might need to change the next day. And I think the messaging from government through to the health system to public messaging needs to be a lot clearer than it has been. And we need public debate around the trade-offs that Catherine mentioned amongst health, economics, and social aspects. And finally, as we mentioned in the article, both in April and the most recent article in the conversation, I think we need to reflect, to learn, and I think we need to rebuild trust in terms of the health system, and we have to have forgiveness if we're going to look forward to 2021 and beyond, how we're going to live with COVID-19 and deal with this long term.
That's fantastic. That's all we have time for. In fact, we're a little bit over our time limit, but I hope you think that was worth it. I certainly did. I really enjoyed this discussion. Thank you both to our panelists, Catherine and Tom, for these fascinating insights. It's been really great. Thank you to our viewers for joining us and for sending in your great questions. We will be bringing you more live discussions on coronavirus and other topics in 2021. So do subscribe to the Conversations newsletter to make sure you're in the loop and keep up with all the latest news and research brought to you by trusted experts like the ones we've been speaking to today. Thank you so much for joining us, and until next time, goodbye.